Good morning, ladies and gentlemen. It's my pleasure to be with you for the Congress of the Colegio Mexicano de Urología. And I would like to thank all the organizers of this meeting for inviting me. It's a great honor, really. And I would like to thank especially my good friend, Dr. Jorge Moreno. I am Enrico FINATZZI. I work in Rome at the University of Tor Vergata, and my role today is to talk about sacral and percutaneous tibial nerve neuromodulation in voiding dysfunction. This is my agenda. I will talk about these two techniques in terms of definition, indications, mechanisms of action, methods, and some idea on what's new, what can be the future or even the present for these techniques. Let's start with the definition. What is neuromodulation? Neuromodulation is a reversible, non-destructive therapy that regulates or modify the electric flow through the neural tissue. So it's a technique able to modify the behavior of our central nervous system. And it's usually performed with the electrical stimulation of peripheral nerves or dorsal root or directly in the spinal cord or even in the brain. Or can be also performed with chemical agents directly sent in the central nervous system. So according to this definition, we can see that both percutaneous tibial nerve stimulation, that I will define as PTNS since now, or sacral nerve stimulation, that I will define SNS, both these techniques can be considered forms of neuromodulation. What are the indications for these techniques up to now, according to the guidelines? The majority of evidence, according to this very interesting review on European urology, for both techniques, the majority of evidence is for the use of these techniques in overactive bladder. So both techniques are indicated for overactive bladder, and the results for both techniques are very good and very well studied. In fact, if we look to the guidelines of the European Association of Urology, for instance, for female LUTs in particular, both techniques are indicated for OAB with a strong level of recommendation. But of course, tibial nerve stimulation is considered a conservative treatment. So it's put a little bit earlier in the course of treatments, while SNS is considered a surgical procedure. So it's put a little bit later in the course of different treatments during the follow-up and the evaluation and treatment of a patient with OAB. But SNS has got also a good recommendation for underactive bladder, and this is different from PTNS, because PTNS is not recommended for underactive bladder, at least in the guidelines of the EAU. A special recommendation for this treatment can be considered the so-called Fowler syndrome. This syndrome was described by Claire Fowler here in the picture in the 80s, and it's a syndrome characterized by a special behavior of the perineal floor, so special findings at the perineal EMG, like this decelerating burst of activation of the perineal floor. So at the end, the problem in these patients that usually are female patients, so usually young patients, is an overactivity of the sphincter with poor relaxation, and that with the consequent difficulty of the bladder to void, and a consequent usually underactivity of the bladder. The indications on the guidelines is less good for tibial nerve stimulation, but still there are some evidence, some papers talking about PTNS in voiding dysfunction. This is a paper of the 2003 done by a Dutch group together with our group on this indication with good results also for PTNS in underactive bladder patients. Then there are other indications like pelvic pain or combined pelvic dysfunction. That means both OAB and fecal incontinence, sexual dysfunction, neurogenic bladder, and also some indication in the pediatric population. But let's say something about the mechanism of action. Why a technique can be good both for OAB and for retention, so both for the both sides of the spectrum. Probably we should talk about the so-called teeter-totter principle. The teeter-totter is this game for kids that you see in this picture, and we have a balance between filling phase and voiding phase of the bladder. But you may have let's say a dysfunction changing this situation of balance in favor, for instance, of the filling phase, and in this case we will have retention, or in favor of the voiding phase. In this case we will have incontinence or OAB. The neuromodulations is able to restore the balance between these two phases, and this is why it's working in both conditions actually. And why is it, where is it working? Probably it's working in the spinal cord, at the spinal cord level, but possibly the most important site of action is the brain. There are several centers that can be changed in their behavior by neuromodulation. This is especially true for sacral nerve neuromodulation, both for AB, like in this picture, and also for patients in retention. So if you apply a sacral nerve neuromodulation, you will change the activity of this site, and you will produce a modification of the behavior of the bladder. There is much less known about tibial nerve stimulation. This is a paper that we produced some years ago, actually, and we were able to find the differences in longer latency sacral evoked potentials after a period of treatment with tibial nerve stimulation. We were able to find differences in this kind of test, so possibly meaning that also PTNS is able to change the behavior of some centers in the brain. And so at the end, we will restore the balance between filling and voiding with these techniques. What about the methods? The methods are very standardized, so probably many of you are familiar with these techniques. This is the PTNS. This is how we stimulate. This is the point we stimulate. We have fixed parameters. We change the amplitude. This is a brief video to show you what we want to have. That is the flexion of the big toe during the stimulation. As you see here, sometimes it's not possible to have this effect, but we can have some feelings on the foot, on the plantar side of the foot, and it can be sufficient to give the treatment. It's an office procedure. Usually it's 30 minutes, and usually we do one session per week. The usual plan is to treat the patients for 12 weeks, so 12 sessions. What about SNS? SNS can start with the PNE, so the evaluation of the nerve, as the third sacral nerve, with a direct with a wire and the stimulator that is not implanted, or can also be used as the first stage implant. So the final lead is placed inside directly with an external stimulator yet, but in this way it's possible to maintain the stimulation for much longer. This is the final situation with the stimulator in place. Of course, there are advantages and disadvantages with both strategies. PNE, it's easier, it's less invasive, but on the other hand, you cannot leave this PNE for very much for very long periods. The first stage, I mean, with the first stage implant, you can leave the implant for much longer periods and to observe the patients for longer periods, but it's more costly and a little bit more invasive. There is this interesting paper by the International Continence Society with best practice statements for the use of sacral nerve remodulation. Here you see some recommendations. I won't go in depth in these slides, but I mean, I recommend you to read this paper if you want to have more information on that. What's new about PTNS? Basically, there is something new about long-term stimulation, because of course the stimulation, the tibial stimulation is good, but needs usually a long-term stimulation. So the patient should be stimulated chronically or continuously with an implant device, for instance. And so there are some new devices. This is the Bionis steam router in this slide. That is an implanted device that can be put in the ankle of the patient and left there and stimulated with an external stimulator periodically to maintain the results that you can obtain with the percutaneous treatment. This is another system, the Blue Wind system. You see in this case there is a cuff around the ankle that is able to stimulate the receiver that is still implanted in the ankle just beside the nerve. These techniques are good to, I mean, have results in the long term. But they are still under evaluation. Still, there is not yet, I mean, a clear indications for these new methods, but they are very promising and very interesting for the future, I guess. Another possibility is to stimulate with a non-invasive form of stimulation, like in transdermal stimulation, and it's something that we do in our clinical practice. We start in the office with the percutaneous stimulation, then we send patients home and they get this stimulation at home with the protocol that the patients can adjust independently. And it's an effective way. Another interesting finding is reported in this paper we published 2 years ago. We reported the results at 7 years follow-up. Actually, I think this is the longer follow-up that is published for PTNS, and basically with good results. And some patients also discontinued the treatment, but still reporting good results in the long follow-up. What's new about sacral nerve stimulation? There are new devices coming. Some few words about the ultrasound guided implant. That is another option of putting the needles, not using the X-ray, but directly the ultrasound. Not particularly new, but very effective. And then, as I was saying, there are new devices with some advantages. This device, for instance, the Axonics, is, I mean, you see, it's a little bit more, it's little in comparison to the interesting, but in particular it's rechargeable, so you don't need to explant the stimulator and change the battery and re-put the stimulator in the patients. And the longevity of this stimulator is higher because it's rechargeable. There are new devices coming on the market, still not available, but with these new devices, for instance, have the possibility to perform MRI in the patients in the full body, not only in the head, without risk for the patients, even if some data seem to indicate that patients can implanted with the SNS can perform MRI without particular risks, actually. And finally, there is the possibility to implant some device in the bladder to investigate the pressure inside the bladder. And if you connect this device with the stimulator, you could have a so-called consequent, let's say, stimulation, conditional stimulation, sorry, only when you need. When the bladder is contracting, you can have the stimulation. When the bladder is not contracting, you can interrupt the stimulation. This is something very interesting for the future. Going to the conclusions, both these treatments are effective. The mechanism of action probably are similar for the two techniques. PTNS is less invasive, but needs a chronic stimulation protocol. SNS is a little bit more invasive, but it's thought as a definitive treatment of the problem. And for sure, for both techniques, possible future improvements will be available probably on the market very soon. And with this, I have finished my presentation. I would like to thank you again for the invitation. And this is my city, this is Rome, this is my university and my hospital. So I look forward to see all of you in Rome to visit my city, and if you want to visit me in my center. Thank you very much.